Hello, my name is Peter Lau. I'm a medical oncologist at Breast Cancer Research Centre WA, Sir Charles Gardner Hospital, Linear Clinical Research, and Sir Charles and Harry Perkins. And it's my great pleasure tonight to chair the Best of San Antonio Breast Cancer Symposium highlights from 2024. Every year in San Antonio in Texas, there's a very small conference there of approximately 10,000 people who gather and talk about the new developments in breast cancer. And it's one of the biggest meetings in the cancer conference circuit each year. So I'd just like to open proceedings with an acknowledgement of country. In the spirit of deepening relationships, I acknowledge all the traditional custodians and owners of country throughout Western Australia and recognise their continuing connection to land, waters and community. I also pay my respect to the elders and extend that respect to all Aboriginal peoples living and working in this area. I'd just like to acknowledge our sponsors, WACOG, the Department of Health WA, Novartis, Roche and Lilly for tonight. And we'll also have the usual post event survey, and also this QR code does provide you with the upcoming events. Just a couple of housekeeping things. Can you please let the staff around circulating the tables at the moment if there's any dietary requirements. For those on Zoom, please ensure your microphone is muted because we really don't want to hear whatever you're talking about and the toilet flushing in the background. And if you could just hold off questions at the end of each presentation. If you're on Zoom, please submit the questions using the Q&A function. So there's also just one other housekeeping item. There is a WACOG conference grants program, and the Cancer Council WA and WACOG are offering 2 grants for advanced trainees, nurses and allied health professionals in a field related to haematology or oncology to a conference of their choice, and applications are closing next month. So we have 4 speakers tonight. We have Dr. Hilary Martin, medical oncologist at Breast Cancer Research Centre WA and Fiona Stanley Hospital. She's going to talk about supportive care. Dr. Louisa Lowe from Breast Cancer Research Centre WA and Sir Charles Gardner Hospital will be updating us on metastatic breast cancer. Dr. Ruan Tay from Royal Perth Hospital will give us an update on medical oncology in early breast cancer. And our final presentation tonight will be from Associate Professor Suka Gill, radiation oncologist from Sir Charles Gardner Hospital, who will discuss radiation oncology related items from San Antonio. So with that, I'd just like to welcome Hilary Martin to the stage. As aforementioned, she's a medical oncologist at Breast Cancer Research Centre WA and Fiona Stanley Hospital, and she's going to talk to us about supportive care. Thank you.
Yep, I think that's all sorted. Yeah, perfect. Okay, thank you for having me to speak. So I'm going to be speaking about supportive care and a bit of survivorship. I have no declarations. I attended from home. I didn't get to buy this duck for the pluck a duck thing I saw on the website. Whoever won that competition, I don't know. So I'm talking about 3 main studies here, actually, focusing predominantly on the Pro-B study, and then a little bit on some obesity, weight loss trial data, and then discussing ctDNA generally, and then focusing on the ZEST trial. So first of all, the Pro-B trial. I think this was one of the most interesting trials from the meeting, actually. So this was a randomised controlled trial of women with metastatic breast cancer across 40 centres in Germany, almost 1,000 women included. And it was evaluating the effect of alert-based patient-reported outcome, known as PRO, monitoring compared with usual care. So in the study, what they did is they had the patients enrolled, and then they randomised them either to the control arm, which meant that they undertook a survey every 3 months looking at their quality of life. So it was an online or web-based tool they used, and they just filled that in. And for the control group, they just collected that data every 3 months. They didn't do anything with the data other than collect it. And then in the intervention group, they had weekly surveys, and then that data was collected as well through the app. But if there was noted to be a significant deterioration in their quality of life, they triggered an alert to their breast centre and to the study central team. Now, a deterioration was defined either as a significant difference in their quality of life scores from 1 week to the preceding week to detect an acute change, and then also they compared the current week with the weeks 3, 4 and 5 weeks prior to that to detect whether there'd been a more gradual longitudinal change that you might not detect by comparing 1 week with the preceding week, but you'd notice if you were comparing from a few weeks before. And so those patients, if it alerted to the local team, they then had to contact the patient within 48 hours of the notification. And then it was up to the local team what they decided to do with that patient when they made the contact. And they didn't report any of the data of what actually happened to the patients with that contact. From the central notification, that just meant that the central team then reminded the local team to make sure they'd contacted the patients at 48 hours. The primary endpoint was fatigue at 6 months, so it was a quality of life endpoint. And then the secondary endpoints were survival at 12 months, and then they looked also at survival for triple-negative breast cancer patients, survival for patients with visceral metastases, and they had a health economic evaluation that was planned that was not reported in this presentation and hasn't been anywhere that I can see so far. Baseline characteristics, so about 1,000 women altogether, around 450 in the interventional, 450 in the control group. Most of the patients were on endocrine therapy as their primary. I don't think that's really alone, but endocrine therapy, and then some also had some chemotherapy or chemotherapy alone, and some were on anti-HER2 therapy. They had quite good response rates for a quality of life questionnaire-based trials, so 92% of those in the intervention arm were filling their responses in at 3 months and 71% in the control arm, and the average alert rate was about 12 alerts per week throughout the duration of the trial. So the primary endpoint, you can see here, so worse fatigue is the higher you get, the higher the score, the worse your fatigue. The top line is the control group, the bottom line is the intervention group. And you can see at the start, the intervention group did have a kind of slight advantage already, but as you went through the trial, this separated out quite significantly over time. And so at the 6-month time point, there was a significant difference favouring the intervention arm in terms of fatigue, and that continued to the 9 months, and there was still separation out at 12 months. So that primary endpoint was met. And then we look at the overall survival, which the curves aren't quite as clearly separated here, but you can probably still see that there is a separation of the curve here. The intervention group is the green on top, so it favoured again the intervention group here. 12-month overall survival, 87.6 months compared to 84.7% in the control arm. So a statistically significant difference in overall survival at 12 months, and this was correlated with a 29% reduction in mortality in the intervention group, which is a clinically significant finding for this intervention. They also looked at the alert rate for patients who ultimately died during the 12 months of follow-up compared with the alert rate for those who didn't die, sort of going back from 0 to 1 month from when they had, 0 to 1 month from when they died, and then further back from when they died. And you can see that the alert rate was very high in the months before death, and it started ticking up about 3 to 6 months beforehand. So perhaps we get a signal earlier, and that's they're intervening earlier for those patients who are gradually deteriorating, and that's why the survival may have been better for those who were in the intervention arm, because we were detecting this. Fatigue improved, so quality of life was better with this measure, overall survival was better. So I guess the considerations for utilising or expanding out a program like this would be looking at what the control arm actually had in terms of their level of support. Were they able to access healthcare relatively easily? Here we have, I think, quite good access for a number of patients through our cancer care nurses. Did they have the same there or not, to know how much it would help here. So it'd be very interesting to get that information, which we don't have at this point. We don't have the data about the intervention following alerts yet, and we don't have the health economic aspect about, so I think this is a very interesting trial, and I look forward to the updated data and more details to come through in the future. So now the other studies I've looked at, there was one of the biggest trials presented at the meeting was one of these early breast cancer trials collaborative groups. This group presents all the time, these Oxford overviews I'll do. People will be familiar when I click across to show the next graphs, but we see them often in meetings and papers. So 206,904 women across 147 trials. There's a lot of patients, and it's looking at whether obesity predicts for prognosis in early stage breast cancer. So here you can see they separated them into 5 groups based on their BMI level, and you can see there's pretty much a linear association worsening as the higher, in terms of distant disease recurrence, as the BMI group gets higher. And then they looked at a subgroup analysis to see whether there was still the same strength of association if patients received chemotherapy or endocrine therapy, or chemotherapy or endocrine therapy together or in sequence, and you have pretty much exactly the same numbers there in terms of the risk of recurrence, so the distant recurrence. So it's no difference based on the treatment, so it's not that we're just underdosing chemotherapy or that endocrine therapy is not getting absorbed, it's just happening for whatever we're doing really there. And then they looked at strength of association associated with estrogen receptor positivity. And that's because there were earlier trials from around 2014 cohorts that reported that for patients who had hormone receptor positive breast cancer, BMI predicted for poorer outcome, but for those for triple negative breast cancer, there wasn't such an association. But you can see here in this data, you've got exactly the same thing happening for both the ER poor, triple negative light group and the hormone positive. So that's no longer the case with our data. So conclusion from this study, obesity is associated with increased risk of distant disease recurrence, but it was a relatively, they thought it was a moderate increase. So it wasn't a huge increase, but still moderate. And I guess from a clinician perspective, the most interesting part of all of this is whether this is going to end up being a truly modifiable risk factor and something that we can subsequently intervene in to address this difference in outcome for this group. And that helps us move nicely on to the next study that I looked at, which was the breast cancer weight loss trial, or BWELL trial. So this was a study of 3,180 patients with early breast cancer. And they were randomised to either health education along with 2-year telephone-based weight loss intervention, or the control arm of health education alone. And they had blood tests done at baseline, 6 months, and then 24 months. The primary objective of the trial was invasive disease-free survival, and then the key secondary endpoints were metabolic and inflammatory biomarkers. So previously they'd reported that there was a 5.7% weight loss compared with their baseline weight at 12 months for the intervention group. And so this trial was reporting on the biomarker. This paper or presentation was looking at the biomarker data, and they had significant improvement in leptin, insulin, and improvement in insulin resistance, and CRP also improved, but not to the same sort of extent as they had in the other parameters. Invasive disease-free survival is awaited. So that's that study. And then the last area I looked at was circulating tumour DNA. So the 2 parts that I went through of this, one was there was a general discussion session actually, and I attended this because I have a lot of patients with early breast cancer who come and ask, can I please have ctDNA monitoring? How can we check that my cancer is not going to come back? Can I have this test? Which test can I have? Can I pay for something overseas? I have a lot of patients with these discussions, and generally, I don't know what to say. Usually I'm like, well, I think we don't have that data yet. I'll have a look, and I have a look, and I can't see anything obvious. This was a very good session because it was key opinion leaders, and essentially the consensus is evidence doesn't support using it for monitoring yet. So we shouldn't be sending any patients. So my patients have said, look, don't, and that's so far I had been telling them I don't think there's anything yet. And this is really what the consensus was at San Antonio from December. It's not recommended outside of clinical trials, and that's really because we don't have sufficient evidence for what to do if we found a ctDNA detected for a patient. So if once we have a trial that shows, yes, we see this molecular residual disease on the ctDNA, there's nothing on scans, we intervene and patients do better because we found it, then we can say, yes, let's do this testing. But otherwise, it's not particularly helpful. And then in the metastatic setting, then obviously the circulating tumour DNA can be helpful for mutation testing that might guide future of their ongoing treatment. So the ZEST trial was presented by Nick Turner, who I worked with at the Marsden, and he looked at patients. It was a large randomised controlled trial looking at patients with early triple negative BRCA wild type or hormone receptor positive BRCA mutation positive breast cancer patients. And it was intended to be a very large trial. They were intending to look at circulating tumour DNA, and for patients who were found to have positive DNA, ctDNA, they were then going to be screened for whether they had any metastatic disease on scans, and then those who didn't were going to be randomised to either receiving niraparib or to placebo, with 200 in the hormone-positive arm and 600 in the triple-negative breast cancer arm. So if you can see here, they got a lot of patients pre-screened, 2,746 patients pre-screened. They then had 1,900 around about entering the ctDNA surveillance. And then with that surveillance, they ended up finding only 147 with ctDNA positivity, so that's a pretty low proportion. And that's because they hadn't really sub-selected out a higher risk group. So they had a very broad range of patients with relatively low risk where you weren't really expecting them to have disease come back. So they had a lot of patients they were surveilling where it was unlikely you were going to find anything anyway. And then when they did find this ctDNA positivity, about half the patients, out of that 73 patients over there that ended up being eligible, had radiologic recurrence at that point. So they hadn't achieved what they'd hoped to do, because what they'd hoped to do was to find disease before you could see it on scans. So it was meant to be this molecular residual disease rather than radiologically detectable disease. And then when they had some other people come out for different reasons, then they only ended up randomising 40 patients as they were going through the trial, and of this very big group from the start, and only 18 in the niraparib arm, 22 in the placebo arm. So it wasn't enough to look at their intervention, and they terminated early the trial because of the issues. They also had a problem with their accrual, really, and that their baseline, their initial patient enrolment, they let anyone enroll at any time from their completion of their adjuvant therapy. So they could have been 2 years out, 3 years out, and later on they changed to 16 weeks post, but they'd already kind of missed out, I think, with that too. So recurrence, they did find that recurrence for patients with negative ctDNA was very rare, but the trial terminated early, and that's it. Is there...
Thanks, Hilary, for that perfectly timed talk. Does anyone have questions for Hilary? Suki, I think have we got roaming microphones tonight? I think we do. Just one moment.
Hilary, do you know if anyone's looked at the role of ctDNA to determine if you need adjuvant treatment?
To determine if you need it at all?
Yeah.
I'm sure there will have been studies looking at that, but not that I'm aware of specifically. No, I don't know. There will be other people who know. Louisa will probably know. There will. But I think the problem with some of these things is you need to, by the time you get that genomic testing back to look for what you're going to track, you may have needed to already start too, because there's that lag time. So there presumably will be some studies, but there's no data that we use at the moment.
All right. Well, I think thanks, Hilary. And I think in the interest of time, I don't think anyone's got any other questions. So we'll just move on to Louisa Lowe, and she's medical oncologist at Breast Cancer Research Centre WA and Sir Charles Gairdner Hospital, and she's going to give us an update on metastatic breast cancer. Thanks.
Thank you. Such a pleasure to be here. So I'm going to present to you the metastatic breast cancer updates from San Antonio 2024. These are my disclosures. I'll be talking through 3 main trials, and if we have time, we're going to talk about the PADMA study and then go towards summary. So to lay the background for the PATINA study, the Cleopatra study was published in 2015 that laid the standard first-line treatment approach in metastatic HER2-positive breast cancer. I recognize a few faces who was handing me brochures when I was a registrar at that time. And that proved that when you add pertuzumab to Herceptin, docetaxel, or paclitaxel as a taxane treatment, that has improved progression-free and overall survival in these patients, and therefore that has become a standard. And just to note that in those patients, endocrine treatment was not used as part of maintenance at that time, even if they have triple-positive breast cancer. And they set a high bar with the median PFS sitting at 18.7 months. So just remember that for the next few slides. And then there's some scientific rationale of combining anti-HER2 targeted treatment with CDK4/6 inhibitors because of the crosstalk in the signaling pathways that can strengthen the anti-tumor effects. So the first question is, in metastatic triple-positive breast cancer, can we add a CDK4/6 inhibitor that we are already using in hormone-positive breast cancer patients in this group of patients to further improve their progression-free survival? So right now, what we're doing in clinic is that we give people 6 to 8 cycles of chemotherapy with trastuzumab, pertuzumab, and then we stop the chemotherapy and keep them going on maintenance, trastuzumab, pertuzumab, add on an endocrine treatment. And the question is, can you add a CDK4/6 inhibitor to further improve that progression-free survival? So PATINA was designed to do just that. They recruited patients with these characteristics, and then they do staging scans of the 6 to 8 cycles of chemo, and only patients who have complete response, partial response, or stable disease were randomized 1-to-1 either to palbociclib plus trastuzumab and endocrine treatment, or they just remain on the control arm of trastuzumab endocrine treatment alone. So the study enrollment enrolled more patients than anticipated, 518 between 2017 and 2021, including a lot of the countries that are showed in green. And 630 were screened, but 112 failed screening. All the patients were included in the analyses. In the control arm, there were 3.5% patients who withdrew, and they were not included in the safety analyses, but all of them were included in the ITT analyses. In terms of the demographics and key characteristics, both arms are very well balanced. The median age was 53 years. 91% of the patients were white. The median cycles of chemotherapy induction was 6 cycles, ranging from 4 to 8 cycles. 97 to 98% of the patients previously used pertuzumab, either in a neoadjuvant or adjuvant setting. In the maintenance phase, 91% used aromatase inhibitor, the rest used fulvestrant. The prior neoadjuvant chemotherapy anti-HER2 treatment use was in 70% of the patients. The best response post-induction, either CR/PR, was 69%, with the rest being stable disease. And here are the results. You can see a very impressive improvement from 29 months to 44 months, and this is historical. I believe this is very difficult to beat in a first-line setting in this subgroup. And you can see complete separation of the curves, with the red line being the palbociclib plus anti-HER2 and endocrine treatment maintenance arm. And when you look at the subgroups, the consistent benefit was seen, whether or not you had previous anti-HER2 treatment or not, whether you had a CR, PR, or stable disease. And you can see 7 to 8% improvement in objective response rate or clinical benefit rates. The overall survival has a similar trend, but you look at the 5-year overall survival, there's a difference about 4%, and it's still immature. In terms of safety, really, we know palbociclib very well now because we have used it in the clinics for many, many years. We know that it can cause some neutropenia, but really is inconsequential. Patients don't really fall sick or needed to be admitted for infections. There's a bit of diarrhea, so overall, it is really well tolerated. So in terms of study conclusions, adding palbo to endocrine treatment in the maintenance phase significantly improved progression-free survival. There's a 15-month improvement. I believe this is really hard to beat. There's no new safety signals, very manageable toxicity, and this is practice changing and sets a new standard of care in first-line metastatic triple-positive breast cancer treatment. So we hope that there will be some actions to try and get access. Currently on PBS, you're not able to access palbociclib for this current indication. The discussion involves whether or not the first-line treatment is going to change, whether or not pertuzumab, trastuzumab remains the first-line control arm, because breast cancer is changing so quickly. Every 3 to 4 months, we get new data. And I do need to talk about the DESTINY-Breast09 data that could come about in 2025. So the reason this is relevant, because T-DXd is now on PBS. It previously replaced T-DM1 in the second-line setting. It has improved progression-free survival from 7 months to 29 months in the second-line setting. And therefore, we await the data from the DESTINY-Breast09 study to know whether or not it's going to replace trastuzumab, pertuzumab in the first-line setting. The second question is going to address patients who have metastatic hormone receptor positive breast cancer. Can we improve progression-free survival in patients who already progressed on an AI plus or minus CDK4/6 inhibitors with new generation oral SERDs in a second-line setting. So currently, we are already using SERD. Fulvestrant is a SERD. It stands for Selective Estrogen Receptor Degrader. It's a monthly buttock injection that patients don't like, and they much prefer oral tablet agents. So right now, there are a few currently surfacing in trials. One of them is imlunestrant. As part of the EMBER-3 study, you have elacestrant from Emerald, camizestrant Sabrina-2, and garadacimab from Accelera. And just to set the background, prior to this, we are already using fulvestrant in combinations. So from the SOLAR-1 study in the second-line setting, if patients have PIK3CA mutations, giving them a combination of fulvestrant and alpelisib would improve the progression-free survival from 5.7 months to 11 months. And as for the Capitello study 291, and patients can use this either in first or second line, and unselected for any mutations, it can bump up the progression-free survival from 3.6 months to 7 months. Although 40% of the population in this study contain a PIK3CA pathway alteration, either PIK3CA, PTEN, or AKT1. So the EMBER-3 study recruited patients who either progressed on adjuvant AI plus or minus CDK4/6 inhibitor, or they progressed on first-line AI plus or minus CDK4/6 inhibitor, and they randomized these patients 1:1 to either one of these three arms, imlunestrant, standard of care, which is fulvestrant or exemestane, or imlunestrant plus abemaciclib. The primary endpoints were investigator-assessed progression-free survival, first of all, in patients with ESR1 mutations, and then A versus B in all patients, and C versus A in all patients. So just a little bit about ESR1 mutations. What are they? So ESR1 mutations, they cause the estrogen receptor to self-activate. They no longer need to respond to estrogen molecule to activate, and therefore that reduces the activity of any aromatase inhibitor. In fact, fulvestrant acts by degrading the estrogen receptor and therefore is not affected by ESR1 mutation. And since 2016, we already know that in patients with ESR1 mutations, if we switch the treatment to fulvestrant compared to an AI, they have better outcomes. And if we add a CDK4/6 inhibitor to that treatment, they also have better outcomes. So ESR1 mutations, they are acquired from previous exposure to aromatase inhibitors such as letrozole, anastrozole, exemestane. There are certain hotspot mutations that you can detect either through the tumor tissue or through a liquid biopsy. And as I said, longer disease control will be obtained if you use fulvestrant and CDK4/6 inhibitors. And this is actually a real-life example of one of my patients that I treated in Melbourne. We took her blood samples from a research study, and as you can see, the level was pretty high, 5,000 copy numbers, and there was an ESR1 D538G mutation. And as the patient started capecitabine chemotherapy, it drops down according to response, and slowly goes back up when they're progressing on the Ribulin chemotherapy. When they're about near death, the levels were sky high at 20,000. And when we switched them to fulvestrant and abemaciclib, it drops down very nicely towards almost nil. And when she was really well, going shopping. But ultimately, when the patient progresses, it mirrors the clinical progression. So back to the EMBER-3 study. In terms of the baseline characteristics in the study population, the median age was 62. 1/3 of the patients had adjuvant-only treatment, and 2/3 had one-line prior treatment for metastatic breast cancer. 60% of the patients have received CDK4/6 inhibitors, but none of them have received PIK3CA or AKT targeted treatments. That begs the question, is this really the right control arm in this study in the second-line setting? So the tumors, 40% of them contain PIK3CA pathway mutations, as expected in the general population. The results show that there is an improvement. If you look at the patients with ESR1 mutations, the PFS is improved from 3.8 months to 5.5 months using imlunestrant alone, which is the oral SERD. And even when you look into the subgroup analyses, it favors the imlunestrant arm, even when patients have visceral metastases, PIK3CA mutations, previous CDK4/6 inhibitors, or whether it's used upfront or second line. And this is just a picture showing you the differences in the curves in patients with ESR1 mutations at the top and those who did not really gain any benefit from imlunestrant. What about the arm that contains abemaciclib? Well, there is more improvement from 5.5 to 9 months, and this is actually in the overall population unselected for ESR1 mutations, and this benefit persists in a subgroup analysis favoring the combination in patients with visceral mets, previous CDK4/6 inhibitors, ESR1, and PIK3CA mutations. If you drill it down to the subgroups that contain ESR1 mutations, that benefit is even more pronounced, improving from 5.5 to 11 months. But even those without the ESR1 mutations, you will still derive benefit, and I think that is very good news. In terms of safety and tolerability, imlunestrant is a relatively safe drug, easy to use. And with abemaciclib, again, we know abemaciclib really well. It can cause neutropenia, a bit more diarrhea, but largely there's no new safety signals from this combination. So in terms of conclusion, imlunestrant significantly improved progression-free survival versus standard of care in patients with ESR1 mutations. And with the combination, it can improve progression-free survival in all patients, unselected for ESR1, and the safety is very manageable and predictable. So, is this expected? The answer is yes, because before this already there are several other SERDs demonstrating similar activities, such as elacestrant in the EMERALD study, in fact FDA approved in ESR1 mutants, camizestrant from SERENA-2, giredestrant and Accelera, and lasofoxifene in a phase 2 study, ELAINE-1. However, oral SERDs still can cause more side effects than fulvestrant in randomized controlled trials. So if you look at this table, camizestrant can cause additional bradycardia, photopsia, giredestrant, transaminitis, bradycardia, imlunestrant, diarrhea, which we don't tend to get with fulvestrant, and elacestrant can cause high triglycerides. So these are additional side effects that you may get with an oral SERD, with the benefit of not needing to have the drug in your buttocks every month. Is it worth it? So this graph shows that there are other trials testing the combination of abemaciclib with fulvestrant to know whether or not that is enough to give you that benefit if you're not using imlunestrant. And you can see this is, I preface, a cross-trial comparison which should not be done. Ideally, you need a head-to-head trial, but there is a signal whereby in these patients who previously received CDK4/6 inhibitors, there's a slight superiority in PFS when you use imlunestrant and abemaciclib. But again, to take caution that this is a cross-trial comparison and statistically this should not be done. I'm going to now move on to the next study, which is the DESTINY-Breast06 study. And to do that, I'm going to give you some background from the DESTINY-Breast04 study. So this study received standing ovation about 2 years ago in ASCO, and it has changed the whole scene in breast cancer. And the reason it has done that is because it has improved the overall survival in patients who have received previous 2 lines of chemotherapy drugs in metastatic hormone receptor patients in the HER2-low cohort. So this is where HER2-low was born. It was because of the DESTINY-Breast04 study. And therefore, T-DXd is now on PBS for HER2-low, hormone-positive, and triple-negative breast cancers who are ineligible for further endocrine treatment and had received prior chemotherapy. And how do you define HER2-low? You know, we create so much work for our histopathologists. We're sorry. But at least more patients are going to get more useful drugs. And what it is really HER2 dish non-amplified, but HER2 IHC1+ and 2+. So that's your HER2-low cohort. Now, since this, there is another study, DESTINY-Breast06, that has expanded that cohort to what we call the HER2 ultra-low. And this section of the patients have staining of less than 10%, so that's not zero staining. There's staining, but it's less than 10%. So these are the HER2 ultra-low patients. And in ASCO 2024, DESTINY-Breast06 actually presented their primary endpoint data. They met their primary endpoint. that have proven that in patients who are chemo naive and progress on endocrine treatment alone, and they're HER2 low and ultra low, randomized to T-DXd and chemo of physician choice, largely capecitabine, they managed to improve the PFS from a median of 8 months to 13 months, and the same improvement sustained in ultra low patients. So this is just a diagram showing you the actual difference in the Kaplan-Meier curve for the progression-free survival in HER2 low and again in HER2 ultra low. So the aim of the San Antonio updates is to ask 3 questions. In patients who progress really quickly on endocrine treatment, do we still see that benefit from T-DXd versus chemo? Second, do patients still derive benefit after progressing on T-DXd, going on a different treatment? Do they still have their biological advantage by starting with T-DXd? The third question is, if you got low burden of disease versus high burden of disease, is it still better to use T-DXd upfront? So the answer is, if you have endocrine-resistant disease and you progressed on endocrine treatment within or less than 6 months, really resistant, the answer is yes. The improvement is from 6.6 to 12 months, a doubling, and you progress, less than 12 months on treatment, there is still improvement from 9.5 to 13 months. And if you started off with T-DXd and move on to another drug when you progress, there is still biological advantage, so supporting the upfront use of T-DXd in this setting. As you can see, the difference is about 6 months. And if you got low disease burden, high disease burden, you got liver mets, no liver mets, visceral disease, yes or no, small tumor size, big tumor size, the answer is yes. T-DXd would offer you that benefit regardless of what situation it is. It's a very positive study. So the conclusion is T-DXd demonstrated a clinically meaningful benefit against treatment of physician choice, and in this case, it's largely capecitabine, an improvement of up to 12.9 months. And efficacy outcomes in patients with primary or secondary endocrine resistance, the preferred choice would still be T-DXd if you're going by evidence-based results. And patients still have that biological advantage if they started off using T-DXd versus using chemo upfront. And regardless of whether you got low disease burden or high disease burden, you probably still want to start off with using T-DXd upfront. So T-DXd is an effective treatment option in patients with hormone-positive, HER2-negative, HER2 low, ultra-low metastatic breast cancer, having progressed after at least more than 1 line of endocrine-based treatment. Do I still have time? 4 minutes. Okay, just to summarize, the PEDMA study is actually a phase 4 study. It's asking the question, if you have a patient who is very high risk, metastatic disease, and you're thinking about reaching for the chemo because these things are changing very quickly, do you still want to do that, or do you just want to start off with endocrine treatment or CDK4/6 inhibitor, and whether that combination would beat the chemotherapy drugs? So baseline characteristics of patients are mostly menopausal, 70% of them have HER2 low disease. Not a lot of them have targetable mutations. Most of the patients who had chemo largely used capecitabine, about 70% of them, and if patients use endocrine treatment, it's mostly aromatase inhibitor. And the answer is endocrine treatment won. So it confirms that if you have that situation, you most likely want to reach out for the endocrine treatment CDK4/6 inhibitor more than the chemotherapy. And you can see the difference is 6 months versus 17 months. And it's the same for the secondary endpoints for progression-free survival and overall survival, same trend. No new safety signals, although 1 patient did die from septic shock on endocrine treatment and palbociclib, which is really ironic because you would have thought that chemo would kill that person with septic shock, but it's not. Conclusion, the PEDMA trial in high-risk hormone receptor-positive, HER2-negative metastatic breast cancer met its primary endpoint, confirming that we should be using standard first-line ET CDK4/6 inhibitor against any chemotherapy use. So just to summarize, in triple-positive disease, adding palbociclib to endocrine maintenance is the new standard first-line approach. The median PFS is improved from 29 months to 44.9 months. Imlunestrant or abemaciclib is a You can be used in the first to second line setting in metastatic hormone receptor breast cancer, especially if they don't have any targetable mutations. But even if they have it, it's proven to work. T-DXd continues to provide clinically meaningful benefit when used before other chemotherapy drugs in patients who are resistant to endocrine treatment, especially if they progress within 6 months of endocrine treatment. And in aggressive metastatic hormone receptor positive breast cancer patients where traditional chemotherapy may be opted for, you may want to now use endocrine and CDK4/6 inhibitor, which remains as first-line standard. And second-line combination targeted treatments is currently limited by no funded access to companion diagnostics except for olaparib in germline BRCA1 and 2 mutations. Special mentions, please refer patients to our current clinical trials, both at BCRCWA and Sir Charles Gardner Hospital. We're looking at Tropion-05 using Dato-DXd and durvalumab in Tropion, a first-line triple-negative breast cancer metastatic setting, gedatolisib in Victoria-1 in second line, maintenance alpelisib for patients who have PIK3CA mutations in NAVO-122, OPERA-1 using palazestrant in the second-line setting. In the adjuvant setting, we have EMBER-4 and BCRCWA in GLORIA study in patients who had non-PCR4 triple-negative breast cancer patients post-neoadjuvant chemotherapy. Acknowledge all the trial participants. Thank you. All the referring clinicians helping us figure out what's the next best treatment in future. And a big shout out to the clinical trial managers, Joe Tonkin and Jeanette Devoto. Happy to take questions.
Thank you, Louisa. That was a really great talk. Just like to open the floor to any questions for Louisa. Yes. If you could just wait for the microphone.
Thanks so much, Louisa. That was a fantastic talk. Yeah, I can't remember which number Destiny study where you have all the median PFS, which look really good in the different. I can't remember which one. Yep.
DB03?
Yeah.
Sorry.
That's right. Yes.
Let's go back to DB03.
Yeah, 03.
Oops.
Sorry about that. Yeah.
Did I overshoot?
Yeah. So.
Oh, I think it was the first one. Sorry.
Yeah. So the median progression-free survival in the different groups look really attractive and positive, but are the overall survival data mature yet, or still not mature?
For the DB06,
yeah,
it's not mature yet.
Not mature
no.
yet. Yeah.
Yeah.
Okay. All right. Yeah.
Sorry, I can't find it.
I sometimes worry whether I guess these treatments are not that toxic, so you would, you use it and give them the more prolonged disease control. I presume you feel comfortable.
I think you have exactly the right question.
Yeah.
So you are thinking, if you have a patient with low burden of disease, they prefer to keep their hair. They don't want to come and have IV treatment every 3 weeks. They don't want to be at risk of lung inflammation because they got background lung disease. Would it be better to give them capecitabine instead of T-DXd, right? Yeah. So I think that is a very individualized discussion. And I think this data help you to select and inform patients that if you put up with all these side effects, you can get this. But if you choose to preserve your quality of life, then this is what you get. So I think that is an individualized discussion with the patients.
I'm just hoping that the overall survival benefit is also significant.
I think
because
that
T-DXd is tough treatment for some patients. Yeah.
Definitely, because but I think as time goes, you also learn to manage the side effects and toxicity. You help to titrate the dose, and we learn how to manage the side effects for patients, and perhaps it will become a bit more manageable in the future. Still, I'm getting patients who are getting uncomfortable with 3 years of TDM1, and they're starting to itch and say, can I stop because there's no activity of disease in my scans? Is it safe to stop? Nobody has that data. So I think we need those trials to ask that question in future.
Thanks so much.
Any other questions for Louisa? I think you're off the hook, Louisa. Thank you very much for your talk. Thank you. And our next speaker is Dr. Ruan Tay. She's the head of department at Royal Perth Hospital, and she's going to give us an update on early breast cancer from San Antonio.
Thank you, Peter. Thank you for inviting me today to talk. I'm going to talk about highlights in early breast cancer today. I've got no disclosures, just some various lunches and dinners. I last presented at a waste meeting in 2013, 11 years ago, and it was for San Antonio, 2013, so I presented in 2014. And these were some of the studies I presented. I think we've come a really, really long way since 2013. I mean, if you look at the studies, we were just talking about endocrine treatment to prevent breast cancer, talking about exercise, bevacizumab, which doesn't exist in breast cancer, and also downstaging, de-escalating treatment, adjuvant paclitaxel and trastuzumab in node-negative HER2 breast cancer. So we did it back then as well. So today I just wanted to discuss 4 studies. I had 7, but I cut them down because I thought it was too much, it was too boring. And I just noticed in the last, between 2013 and now, there's been a cycling. People have talked about escalating treatment because more is safe and secure. People have talked about de-escalating treatment because less is more. Less treatment causes less side effects, and then prescribing treatment that was tailor-made to the patient. So we'll show you 4 studies that try to go round and round in circles with these 3 concepts. Firstly, I'd like to talk in the hormone receptor positive setting, the impact of anthracyclines in high genomic risk node-negative breast cancers. In the triple negative setting, we'll talk about Gepa-12 or Gepa-12. In the HER3 setting, we'll talk about TRAIN3, and then I thought I'll give you an Olympia update. I'll try to choose these trials just because they've got a bit more clinical relevance, whereas a lot of these trials, is what's to come, but I think these ones may change how we treat our patients now. All right, the first study was the impact of anthracyclines in high genomic risk node-negative, hormone receptor positive, HER2 negative breast cancers. This was done in the background of us knowing anthracyclines may not be necessary in treating breast cancer, and we can try to spare patients from anthracyclines and just give them taxane-based treatment. Because anthracyclines have side effects, and that can be long-term, mainly with cardiotoxicity. So this is actually a post-hoc analysis from the TAILOR-X trial. For those who can't remember, the TAILOR-X trial looked at Oncotype DX, and at that time we knew that patients who had a low recurrence risk, or this one here, arm A, low recurrence risk score of 0 to 10, they didn't need chemotherapy. The benefit of chemotherapy was less than 1%. And then arm D here, we knew that they needed chemotherapy. They had a high recurrence risk of 26 to 100, and they should have chemotherapy and hormone therapy. At that stage, we didn't know what to do with this people here who had a recurrence score of 11 to 25. And the TAILOR-X study, they were randomized to the experimental arm, which was endocrine treatment only, or standard treatment, which was endocrine treatment and chemotherapy. So this study here that was presented most recently took pretty much people from standard arm and high risk arm and see who had anthracycline and taxane-based chemotherapy and who had taxane-based chemotherapy only, and compared them. All right, so this is the patient characteristics. As you can see in the TAC, so that doublet chemotherapy arm, the patients were younger. They had more patients who were premenopausal. The tumour size was bigger and higher grade, and they tend to be less, or tend to have more PR negative cancers. So putting this together, the part where the physicians got to choose treatment, they pretty much chose to give doublet chemotherapy when they thought the patients were at higher risk of recurrence. The recurrence risk score was also higher in the doublet chemotherapy arm, and just showing you here what type of chemotherapy they had, which is pretty standard. We tend to use this one now, dose dense AC paclitaxel, but we also use TC as well. And these were the results. So for recurrence-free interval at 5 years, there was no difference between anthracycline and taxane doublet chemotherapy versus taxane chemotherapy alone if your recurrence score was less than 31. If your recurrence score was greater than 31, there was a difference, and you should be giving doublet chemotherapy if you can, with the difference being about 5%, which was statistically significant. This was the secondary endpoints, which was distant recurrence-free survival, which also, again, was statistically significant with this 5% difference. The only thing that wasn't statistically significant was overall survival. And I think this may be the case because we have lots of good drugs now in a metastatic settings, and patients are living longer and longer, and it's quite hard to achieve an overall survival benefit in adjuvant trials nowadays, especially with ER-positive breast cancers. This was the subgroup analysis, and there was not really a certain group, except for patients who had higher, bigger than 2 centimetre cancers. So the bigger your tumour, the more likely you should use an anthracycline. And then lastly, they teased out the figures to see what the benefits of the anthracyclines are according to recurrence score. And as you can see, the higher the recurrence score, really the better, the more you need the anthracycline. And the cutoff they used was 31. So in conclusion, in patients with hormone receptor positive HER2 negative breast cancers, if you use Oncotype and your recurrence score is greater than 31, you should try to give them anthracycline-based chemotherapy even though we don't tend to do that for lymph node negative cancers. If their recurrence score is greater than 31. And I think this is going to change what I do, because I do send a few patients, not that many, for Oncotype DX. And to be honest, most of the time they do come back as low risk because we're sending the test to make sure that we're not doing the wrong thing, not saying no to patients who want to have endocrine therapy only. But if they do come back with a high recurrence score, we should consider doublet chemotherapy. Okay. Next, we'll move into the triple negative setting. This is a study by the German group. This is JEPA-DUCE, so JEPA-12. It's looking at standard chemotherapy neoadjuvantly with atezolizumab. So instead of pembrolizumab, we have atezolizumab. Just as a reminder, this is quite a pivotal study, the Keynote 522. It's now what we do as standard treatment for triple negative breast cancer, which is carboplatin and paclitaxel with pembrolizumab, followed by AC with pembrolizumab, surgery, and then more pembrolizumab. And this study was recruited between 2017 and 2018, really quickly, I think. 18 months is really quick. And they had 1,174 patients, and their results have read out to be positive in both their primary endpoints, positive in PCR rates, positive in event-free survival, and their secondary endpoint of overall survival has also been positive, and this trial was first published in February 2020. So the study design for JEPA-12, they were aiming for 1,550 patients, so quite a bit more than Keynote 522. It was the same group of patients and the same criteria, and the chemotherapy backbone was the same, except they did allow for AC, EC every 2 weeks instead of every 3 weeks should the investigator wished to do so. And then of note is, oh, it's not written here. Okay, I'll do that. Oh, yes, here it is. Of note is at at the end of their treatment recruitment, they allowed capecitabine for non-responders or non-PCR patients. So we just need to remember that when we look at the results. Primary endpoint was event-free survival, secondary endpoint overall survival and PCR, whereas in 522 they had pathological complete response as a primary endpoint as well. So they took a very long time to recruit compared to 522. I think the reason for that is they had a 1-to-1 randomization, whereas in Keynote 522 they had 2-to-1, so 2 people got Pembro and 1 person got placebo. And you tend to recruit faster when it's more attractive and you're more likely to get the trial drug. So they took ages, 3.5 years. They did manage to recruit 1,550 people. And this was the patient characteristics. It was very well matched across the board. Nothing that stood out. Oh, the only thing that stood out, sorry, was, oh gosh, wrong way. How do I go back? Oh, actually, no, we'll leave now. Sorry. So this was the results. Unfortunately, it was a negative study for their event-free survival. There was no difference between the placebo arm and the treatment arm with atezolizumab, with the event-free survival being about 82% on the placebo arm and 85% on the atezolizumab arm, and it was not statistically significant. The types of event-free events were pretty standard, with distant recurrence being the most common area of recurrence. This is the subgroup analysis for EFS. And the thing that stood out the most was patients who had node positivity did actually derive more benefit, and it was a positive P interaction for that. And then interestingly, looking at their secondary endpoints, they did achieve a difference in pathological complete response. So there was a difference of 57% versus 63%, and that was statistically significant. But it didn't correspond if you were a pathological complete response, it didn't change. And if you were a non-pathological complete response, it didn't change. And this is actually where Keynote 522 was more successful. There was a wide difference for the non-pathological complete responders. And could this be because half the patients had capecitabine? So this is Keynote 522. As you can see, that's where you can see the biggest separation is those who had RCB class 2 response. And there was no difference in overall survival. In terms of immune-related events, it's pretty standard. Hypothyroidism, which is what we see in real life with pembrolizumab. So conclusion, the addition of atezolizumab to neoadjuvant chemotherapy and followed by adjuvant atezolizumab did not change event-free survival, but it did change pathological complete response. We don't know why that is, and it could possibly be mitigated by having capecitabine. And I know all of us, even though capecitabine wasn't allowed on Keynote 522, I know all of us still use capecitabine on top of pembrolizumab in real life. This just shows how pembrolizumab is actually one of the best outcomes. It's like top 5. Tamoxifen versus none has the biggest overall survival gain. Polychemotherapy versus none, second best. Trastuzumab has been a real changer, and now pembrolizumab. Although we don't have the overall survival outcomes for the CDK4/6 inhibitors yet, but I'm sure that will be up here somewhere. Now we move on to the HER2 setting. I thought this was quite a nice study. It probably won't change our clinical practice, but it might make us feel a bit more comfortable in the fact that many of us have patients who have 1, 2, or 3 cycles of chemotherapy and then they give up because, they've come in with sepsis, or I've had a couple of diverticulitis and perforations and needing stomas, and then they say, I don't want to have chemo anymore. But they tend to then have really good responses. And are those responses, does that equate to good outcomes and good prognosis? And so this study was very nice in that it did look at stopping chemotherapy after 3 cycles, 6 cycles, and 9 cycles if they were found to have a good response on MRI. So that's the rationale. I already went through it, sorry. And so this was the study design. They looked at stage 2 to 3 HER2 positive breast cancers. They had 3 cycles of paclitaxel, trastuzumab, carboplatin, and pertuzumab, slightly different to what we use here in the chemotherapy taxane, the taxane we use. After 3 cycles, they had MRI evaluation. If on MRI they look like they've had a complete response, they went on to have surgery. And then if histologically they did not achieve PCR, they will then complete up to 9 cycles of chemotherapy. If they did achieve PCR, they will go on to just completing their monoclonal antibodies of pertuzumab or Herceptin. If at that response evaluation they didn't have PCR on MRI, they went on to have another 3 cycles of chemotherapy. And again, if they have PCR, if they had complete response radiologically, they went to have surgery, and so on. So up to 9 cycles of chemotherapy. These were the patient characteristics, and it showed they were all fine. Just this one here, the pathological complete response rates. You can see actually, if you're HER2 negative, 34% or a third of patients can achieve PCR after just 3 cycles of chemotherapy. And up to 80% achieve PCR after 9 cycles of chemotherapy. It's not so good on the ER positive cancers, but still not too bad. 16% after 3 cycles and 43% after 9. So their primary endpoint was event-free survival at 3 years, and you can see even though they had a truncated course of chemotherapy, their event-free survival there was no difference if they achieved pathological complete response, especially here. If they only had 1 to 3 cycles and had achieved pathological complete response, they did really well. It did drop down the more cycles you needed, meaning that the cancer the patient has probably is not as sensitive to treatment, needs more treatment, and their survival is not as good. Safety, as predicted, less grade 3 and grade 4. Adverse events if you have less chemotherapy, less hematological, and less neuropathy as well. So in conclusion, 1 in 3 patients with hormone receptor negative, HER2 positive, and 1 in 6 patients with hormone receptor positive, HER2 positive breast cancers can achieve pathological complete response with only 3 cycles of neoadjuvant chemotherapy. These patients have excellent 3-year event-free survival and overall survival. PCR can be identified with MRIs. They didn't talk about this very much in this at San Antonio because this was previously presented, but they did find in the previous presentation that MRI accuracy to predict PCR was 87% for her ER negative and, sorry, I can't see that, blind, 53% for ER positive. Alrighty, and this therapeutic approach offers this significant reduction in toxicity. Alrighty, last one is Olympia, and the reason I put Olympia up is I still don't know what to do. if patients do turn up to be BRCA, and it'll be good to hear from others as to what they think we should do if patients are eligible for abemaciclib and olaparib or pembrolizumab and olaparib. Yeah, I haven't had a chance to encounter a patient who is in this dilemma, but it would be good to hear what others think. So Olympia, as you know, is a study looking at PARP inhibitor, olaparib, and seeing if it provides benefit for patients with BRCA mutations. And I'm sure everyone knows that it was run at Charlie's, and we all sent patients there quite a few years back. This was the trial schema. Olaparib's now available on the PBS. I won't go through this for time's sake. I don't know how much time I have left. This was the patient characteristics, and this is what they presented, the updated invasive disease-free survival. At 6 years, you can see an extra improvement of 1% from 4-year data. And again, distant disease-free survival, a bit less of an improvement, but still an improvement at 4 years. This was the subgroup analysis, no real difference in any of those. You derive benefit from ER positive as well as triple negative cancers. This is overall survival, and they do have an overall survival benefit of 4.4% at 6 years. Adverse events, we were worried that it may induce or cause more myelodysplasia or AML, and it's good to know that actually that's not the case, with 6 patients on the placebo arm getting MDS or AML and only 4 patients on the olaparib arm. And we also looked at whether it prevents new malignancies, and not really. We don't think that it really did do very much. So at 6.1 years, after 12 months of olaparib, it looks like it's a great drug. But what I really want to talk about is this. This is the PBS criteria for olaparib. It seems pretty strict. Especially this part here. The treatment must be commenced within 12 weeks of completing other therapy, noting that other therapy can be any of the following: surgery, radiotherapy, chemotherapy. And the treatment must not be in combination with any of the following: abemaciclib and pembrolizumab. So which one would you choose, olaparib or abemaciclib? So this is the curve for abemaciclib in the Monarch E study. They have a statistically significant disease-free survival of 85.8% versus 79.4%. And then olaparib or pembrolizumab, which we've already talked about. I don't know. You would choose olaparib? Okay. Yes, that's right. I think the rationale is... Yeah. Do you do mainstreaming? Yeah. I find like since I started mainstreaming, I'm finding a lot more BRCA and PALB2 patients than I used to.
The overall survival data is very convincing. The overall survival data is very convincing. I have seen patients with BRCA2 mutations progressing really quickly on hormone therapy and CDK4/6 inhibitors, do really well on PARP inhibitors in the hormone receptor positive setting. So I agree with Albert.
Yeah, I think that's really helpful. Thank you. Oh, I'm on call. Hold on a minute. Thank you for listening. This is my shameless plug. If you want to take out your phones and scan the QR code to my Instagram at the beginning, you saw a couple of cakes. That's my cakes and my food. Thank you.
Thanks, Roanne. Just see if there's... just got time for one quick question from anyone. I think you're off the hook, everyone. Okay, thank you. Next speaker is Suki Gill, radiation oncologist from Sir Charles Gardner Hospital, and he's going to give us an update on everything radiation oncology from San Antonio. Thank you.
Thank you, Peter. So everyone's enjoyed a wonderful dinner, I hope, and I can see a lot of postprandial faces in the room. I have two young girls, and I find to keep them interested, I often have to make things interesting. So the way I do that is I often tell them a little secret, and then I play a little game. So I'm going to start with telling you a little secret, and I hope the radiation oncologists in this room will forgive me for sharing this. But all radiation oncologists actually, in the back of their mind, are thinking, when are we going to jump ship and become medical oncologists? So that's a secret. And then now the game. So the talks I'm going to talk about tonight is the Europia study, the Supremo study, the COMET study, and tamoxifen only in DCIS. And just to make it interesting, we'll call hormone therapy medical oncology world, basically. And I'm going to put my badge here. So it's a competition. So every time medical oncology wins, it'll go that way. And then every time radiation oncology wins, it'll come this way. So in the end, if medical oncology win, then we're gonna, that's gonna go that way, basically. So, oops. I'll just use that. So the first study is the Europa study, and this competition basically is between tamoxifen and radiotherapy. So we all know that you don't have to give radiotherapy to patients above the age of 70. You could just give them hormone therapy, and the rate of recurrence is approximately 1% per year higher if they just had hormone therapy after wide localization for T1 N0 breast cancer. And that was shown by Prime 2 study and also by the previous randomized study by Hughes et al. So the one very interesting thing about the Europa study is it actually looks at quality of life and compares hormone therapy versus radiotherapy. And can I have a show of hands who thinks here that hormone therapy would win in terms of quality of life, and who thinks that radiotherapy would win? Thank you. So this was a randomized trial. They could either have whole breast radiotherapy or partial breast radiotherapy, and they could have the standard 3 weeks or the hypofractionated 5 days of radiotherapy. And of course, the endocrine therapy could either be tamoxifen or arimidex, depending on suitability. And 85% of them only had 5 days of radiotherapy and partial breast in this good prognosis group of patients. And so this is just to show that they were fairly well distributed. They were not just the high risk or the low risk patients. Grade 1, grade 2, T1 to T3, and all above 70 years old, basically. And so the first primary endpoint was the quality of life. And I can tell you now that quality of life is very difficult to measure and prove that something that you do to a patient actually makes their quality of life better or worse. And this was a EORTC QLQ-C30 questions. And you can see there that the endocrine therapy had a worse quality of life compared to 5 days partial breast radiotherapy. So the G8 score is a questionnaire that looks at frailty. And here again, you find that patients who were 70 or over who had endocrine therapy were more frail after they were started on hormone therapy compared to those who had 5 days of radiotherapy. And this is another one looking at functional scale, so the ability to do their normal EORTC questionnaire function, and that was also improved with radiotherapy, better with radiotherapy. Sorry, this was the one that showed that there was less kind of breast symptoms with radiotherapy. So radiotherapy actually caused less breast problems, which I really don't understand. But yeah, so So yeah, so they were even with breast questionnaire, there were less problems, probably because their ability to cope with it was worse. So treatment-related adverse events was higher with endocrine therapy compared to radiotherapy, and that this difference was statistically significant, and there was no difference in their survival outcome in the end. So for the first win, we moved radiotherapy, the badge, a little bit closer this way. Oh no, I've really screwed it now, haven't I? How do we do this? Oh, help. There goes my game.
No problem. Yeah. Let's see if we can get it back.
Just to keep everyone interested, I would share another thing with you that I'm actually absolutely bursting for the toilet, but I was just waiting for Louisa to put more of her cake photos, but then she put this link at the end. So, but thank you, Louisa. Very good talk. And so by 2 years, 20% had changed their endocrine therapy, 12% had stopped their hormone therapy altogether. But yeah, this is fairly standard, I think. So then, of course, there is also the option of tamoxifen only or hormone therapy only for good risk DCIS. So there were 2 studies, basically randomized studies, that looked at no radiotherapy. One of them was single arm, ECOG Acrin E5194, and the other one was the NRG Oncology RTOG 9804. So these studies basically looked at omitting radiotherapy altogether for patients with good risk DCIS. And how did they define good risk DCIS? So in the 1990s, there was a committee put together, and they defined patients with size less than 2.5 centimeters, grade 1 or 2, and margins more than 3 millimeters as likely to be the better risk prognosis-wise for DCIS. And so that led to these 2 studies, basically. And in this, what this study actually did was they looked at the subgroup that were treated with tamoxifen. And they actually found, so 878 patients were given tamoxifen to see whether tamoxifen actually improved their recurrence-free survival. And who thinks here that tamoxifen is useful in DCIS and that we should test for tamoxifen? Excellent. Yeah. And me, there's 3 of us, great. So overall, ipsilateral breast recurrence was reduced by 7% with tamoxifen in the group that had tamoxifen when you avoid radiotherapy. The invasive breast cancer was what was being reduced. So it's not just DCIS which is being reduced. That was reduced as well, but only by 3%. But invasive breast cancer was reduced almost by half. We often say, oh yeah, this is chemo prevention for the other side. That's BS. There was no reduction in risk of recurrence in the other breast, basically. So that was another win for tamoxifen, but I think that radiotherapy had already lost that battle, so we're not gonna shift the badge, especially after what I did last time. So okay, this study is very, very interesting. So Ian Kunkler from Glasgow, Edinburgh, he's a Scottish radiation oncologist, looked at post-mastectomy radiotherapy, and in patients who have a particularly indeterminate, so that group where we were never sure whether they should have post-mastectomy radiotherapy or not, and it's a 10-year results. So in 1997, there were 2 randomized trials, a Danish study and a Canadian one, that showed a survival benefit in patients with 1 to 3 positive lymph nodes. By 9%, their survival was improved with post-mastectomy radiotherapy when you did it in patients with 1 to 3 lymph nodes. So this is then analyzed in the EBCTCG meta-analysis, and they found that post-mastectomy radiotherapy reduces risk of recurrence locally from 20% to about 4%. So benefit for post-mastectomy radiotherapy. So the only thing is this is using old chemotherapy. So not just was the use of paclitaxel and Taxotere is new, but also patients' ability to tolerate chemotherapy has become better because of better antiemetics, so they can actually complete their cycles on time. And there's other supportive therapies that they can give, like to boost their neutrophil count. And now, of course, Herceptin came in 2006, 2007, and then there's other new drugs that have come recently. So all these basically reduce the number of people who fail their treatment, whether it's surgery, radiotherapy, but then it also then reduces the benefit from other treatments, basically, because chemotherapy has become so much better. So this study is now in the modern era of chemotherapy. Do we still need to give post-mastectomy radiotherapy in those with 1 to 3 lymph nodes? And they did include in their study patients with tumors which are T3 and 0, which are more than 5 centimeters. Again, they looked at a number of factors, including overall survival at 10 years, local recurrence, disease-free survival, and quality of life. So this was a recruitment. There were 1,600 randomized, so 800 in each arm, and analyzed by intention to treat. And the characteristics were fairly well distributed. The only thing to note was the number of patients with, gosh, that's small. 0 lymph nodes was quite small. I think that's 0.5%, but it is very, very small. I apologize for that. So overall survival, no benefit now. So patients with 1 to 3 lymph nodes did not have a survival benefit from radiotherapy following a mastectomy. And again, this were looking specifically at those with node negative and node positive chest wall recurrences and overall survival. There's no benefit, basically. So local recurrence, it was statistically significant. When you do a study with really large numbers, it's quite easy to get that p-value, but the clinical benefit was only a 1% difference in local recurrence, 2.5% versus 1.1%. So I think anyone would say that's probably not clinically significant in terms of chest wall recurrences, basically. So this is analyzed based on just the node negative and node positive status again. So in conclusion, patients with 1 to 3 positive lymph nodes don't benefit from radiotherapy according to this study. So I don't know how this is going to change our practice. Probably has only just come out, and I think we still have to discuss as a group how this impacts us, basically, and also not published. So then the next study, sorry, I think my badge has just dropped to the ground there. So then the next study or the last one, thankfully, is a COMET study. I'm sure everyone's very excited to hear what happens if you don't do anything for low-risk DCIS. And they've so far published their 2-year results. So no surgery. So any surgeons in the room, there is room to retrain in medical oncology. So here it is, low-risk DCIS. So how do they define it? Age more than 40, no invasive cancer, grade 1 or 2, ER positive, and they had to biopsy it twice if it was more than 4 centimeters in size, just to be sure it was consistent and it was not like different pathologies in different parts of the cancer. They were looking at stratification by age, so less than 55, 55 to 65, more than 65, stratification by diameter, I mean, up to more than 5 centimeters of DCI, so they still didn't treat them, basically. So far, at this 2-year survival point, and they looked at multiple things such as quality of life and so on, which is reported in a separate presentation. But so they had 957 patients. Half of them had their guideline treatment, which is surgery plus minus radiotherapy, and then half of them have just active surveillance or active monitoring, a bit like prostate cancer. So this is the subgroup analysis. Again, you can see it's very well distributed. Even under 55, there were 226 patients who were randomized. And even grade 2 DCI, most of them, in fact, are grade 2 DCIs. And here we go. There's so far no no difference in cumulative risk of invasive breast cancer. And this is the intention to treat analysis, again, looking at invasive breast cancer. And again, p-values are so far not significant. So it's still early. I think DCISs can progress after 2 years, but this suggests that doesn't progress that quickly. Thank you very much. Okay.
Oh, thank you, Suki, for that great talks.
Can I join your medical oncology group now? Is it? Is it too late?
We can make an honorary members, Suki.
Thank you.
You can take all the BCISS patients.
I can't spell any of the drugs, so that's the only problem.
It changes every 6 months anyway. That's right. Does anyone have any questions for Suki tonight? Or I think that it was a great talk, and it was really quite clear. And
Thank you so much.
the drugs usually work. All right. Well, that brings tonight's evening to a close. I'd just like to thank Hilary, Louisa, Ruan, and Suki for their time in these very terrific and educational presentations tonight. I'd just like to thank our sponsors again, WA Health. Hang on. Where's that slide gone? Sorry, someone else is controlling this, not me. Thank you. Novartis, Roche and Lilly. And we'd really greatly appreciate if you could fill out the evaluation forms that are probably sitting in your email inboxes right now. It really does help us plan for the next events. So with that, thank you and have a good night.